The next part of diabetes includes screening for its complications and comorbidities in patients with diabetes mellitus. First, let's look at why patients may present with complications when diagnosed for the first time. We now know 90% of the cases belong to type 2 diabetes mellitus. Hyperglycemia worsens at a slow pace, and therefore symptoms are not severe or may be absent. As a result, in the absence of biochemical testing, hyperglycemia is sufficient to cause pathological and functional changes and may be present for a long time before a diagnosis is made, resulting in the presence of complications at diagnosis. It is estimated that a large number of cases, nearly 30 to 80%, are undiagnosed. When we screen for complications of diabetes mellitus, we have to consider the common complications of type 2 diabetes mellitus and what we need to ask clients in the history to elicit complications. First, let's look at screening for complications of diabetes clients. In the visual system, they can present with glaucoma, cataract, retinopathy, or macular edema. When taking the history for glaucoma, they complain of gradual deterioration of vision. In case of cataract, they will complain of eyes, clear lens clouds, or blocking sight. In case of retinopathy, they will complain of vision impairment, and in macular edema, they will complain of vision blurs, which can be eventually lost entirely. In the examination viewpoint, we focus on any vision impairment and perform an ophthalmoscopy examination, including a retinal examination. Patients can also develop nephropathy presenting with non-specific symptoms such as malaise, tiredness, loss of appetite, decreased urine output, and frothy urine. On examination, they may be found to have pallor, periorbital or ankle edema, and body itching. Investigations that can be performed are urine dipstick for protein, serum creatinine, hemoglobin, and serum electrolytes. In the presence of albumin or protein, it is significant when there is no urinary sepsis at the time for urine collection. In females, urine samples should not be collected during menstruation to avoid contamination. Urine albumin creatinine ratio, early morning spot urine sample, is preferred. Microalbuminuria is defined as the excretion of 30 to 300 milligrams of albumin per 24 hours on 2 of 3 urine collections. Another complication they can present with is peripheral neuropathy, and in the history they will complain of tingling pins and needles in feet, pain or increased sensitivity, burning, stabbing or shooting pain in the feet, numbness or weakness, and unsteady gait. On foot examination, we check for blood flow, check for numbness, deformities, callosities, ulcers, and ingrowing toenails. Next, we will look at autonomic neuropathy, where in the urinary tract system they can present with bladder control problems, urinating very often or not often enough, and frequent bladder infections. In the gastrointestinal system, they will complain of indigestion or heartburn, bloating, nausea or vomiting, undigested food, diarrhea, and constipation. Men will complain of erectile dysfunction, fainting after getting up or changing of position, or suddenly for no reason, palpitation at rest is one of the complaints with regard to cardiovascular system. Next, we look at how you would screen for comorbidities of diabetic clients. In the history, we look for a family history of ischemic heart disease, premature cardiovascular diseases, and diabetes in first degree relatives. Male relatives less than 55 years and females less than 65 years. We also inquire if she or he has smoked any tobacco products such as cigarettes, cigars, pipes, or consumed smokeless tobacco within the last year? Has she or he consumed alcohol in the past year? Is the patient engaged in regular physical activity equal to or greater than 30 minutes per day, at least 5 days a week? On examination, we focus on examining the blood pressure for the first group and BMI for the last group. We check the total cholesterol or lipid profile after 12 hours overnight fasting and assess the cardiovascular risk using the WHO ISH risk prediction chart. In this slide, we have annexed the diabetic foot risk assessment form, as diabetic patients are at higher risk for a variety of foot health problems. We check for injury, infection, and bone abnormalities and alignment changes. Neuropathy and poor circulation are the most common causes of diabetic foot problems. A diabetic foot exam ideally needs to be performed at least once a year, but may need to examine it more often if symptoms in feet appear.